talk quickly and give an update on ANCA-associated vasculitis. As you will all know, these are multi-system diseases that affect the kidney very commonly. They're characterized by a circulating autoantibody in the vast majority of cases, which is called an anti-neutrophil cytoplasm antibody. About 10% of cases will be ANCA negative, and there is a renal limited form of the disease, which we think, to all intents and purposes, behaves the same and responds to treatment in exactly the same way, although we don't know or completely understand why this small minority of cases don't have a circulating antibody. And I'll show you that there are significant disease-associated morbidities and mortalities, but we have now converted what was a life-threatening disease into a treatable condition, but we have caused significant harm from some of our treatments. And so the challenge we have is to try and improve the outcomes without causing harm with the treatments we're using. So just to rehearse this, there are three clinical syndromes that you will know about: microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. We've lost the eponymous names of these conditions to try and understand some of the pathophysiology and the etiology of these diseases. And you can see that there are some differences between these three clinical conditions. MPA can be renal limited, and I know, at least, I don't know about Sri Lanka, but I know from India that there are a number of cases of porcine immune glomerulonephritis that are ANCA negative that behave exactly the same as MPO, renal limited disease. GPA is characterized by granulomatous inflammation, predominantly in the upper and lower airway, and EGPA is essentially an allergic phenomenon on top of a vasculitic component with significant eosinophilia. So one slide on pathogenesis, which I think explains very nicely everything that is going on. Genetically predisposed individuals who have certain polymorphisms, when exposed to the right environmental antigens, lead to loss of tolerance to either proteinase 3 or MPO, myeloperoxidase, the two antigens associated with autoantibodies. These generate autoreactive T and B cells, and they lead to the formation of the ANCA. ANCA will bind neutrophil surface MPO or PR3, stimulating neutrophil activation, release of neutrophil extracellular traps, release of proteases and enzymes, and undergoing a reactive oxygen burst. This will cause endothelial injury, and this is shown here in the left-hand picture, neutrophils degranulating and damaging the endothelium. As a result, they will also release PR3 and MPO. This will then feed back into this cycle, stimulating more autoreactive T and B cell activation. And so there's a positive inflammatory loop that occurs once the disease is initiated. In a subset of people with granulomatosis manifestations, the autoantigens seem to promote giant cell formation and granuloma formation, and there are some experimental data suggesting that it's PR3 itself that's stimulating the monocytes to form these giant cells. So what does it look like when you have neutrophils damaging at the endothelium? You can actually get fibrinoid necrosis of the small vessels. Here you can see a vessel whose vessel wall is intact, and here it's undergoing fibrinoid necrosis. It's breaking down, and it's releasing leukocytes and contents of the circulation into the tissue. So these organs that are downstream of this vessel will have ischemia and will have infiltration of inflammatory cells into the tissue. So what does that look like when it happens in the eye? We get an anterior uveitis or a scleritis. In the skin, we get the petechial rash that we see. And in the kidney, we will get the focal necrotizing glomerulonephritis that is familiar to us all. In the lungs, obviously, we'll get lung hemorrhage. So kidney involvement is very common in both MPA and GPA, less common in EGPA. If you look at biopsy series of patients biopsied for acute kidney injury, systemic vasculitis is one of the commonest findings that is present in two different biopsy series. And if you look at what happens with renal involvement to the patient, if you have renal involvement at presentation, a significant proportion will go on to develop end-stage kidney disease, and that portends a much poorer general outcome with a very high mortality. So 1 year survival with ANCA vasculitis in the current climate is around 82 to 89%, suggesting that we're losing a significant number of patients in the first year with a worse outcome than many common cancers. So these are data from London looking at the presenting creatinines and the outcomes of patients over a 40-year period. And what it shows you is that the presenting creatinines in these cohorts over these decades seems to be coming down, suggesting, I think, that we're picking up this disease much earlier, which isn't surprising because antibody testing has become readily available, and I think people are more aware of the diagnosis. And with that, there is an increase in survival both at 1 year and at 5 years. So perhaps earlier detection of disease is associated with better outcomes. So prior to immunosuppression being available, this is what we would call the natural outcome of patients with ANCA vasculitis. This is GPA as it was in the 1950s, prior to steroids, prior to any form of immunotherapy. 85% 1 year mortality. In the 1970s, Tony Fauci, latterly known for his work in COVID, started trials looking at cyclophosphamide and steroid treatment of patients who had ANCA vasculitis, and really reversed what was a high mortality rate, showing that most patients now went into remission, survived, and many of them survived off therapy. But this came at a cost, and the cost was what we know in terms of treatment-related side effects from cyclophosphamide, especially at the doses it was used then, and corticosteroids. So over the next 25, 30 years, a number of trials have been carried out to try and see if cyclophosphamide dosing could be reduced or completely avoided. And not that you need to look at all the details, but essentially whether you use a shorter course of cyclophosphamide or substitute it for methotrexate, or use it intravenously pulsed as opposed to orally, or avoid using it at all and use rituximab instead, or mycophenolate. Remission rates were more or less the same between the two arms of these studies, so suggesting that you don't need to use cyclophosphamide in the same quantity as it was used earlier to get the same percentage of people into remission. The disappointing outcomes of these trials was that there was absolutely no difference in the adverse events that occurred as a result of altering the treatment. So infections, infections and morbidity and mortality were very similar regardless of the induction that was used, even if you avoided cyclophosphamide completely. So the question then became, well, maybe it's not the cyclophosphamide, maybe it's in fact the steroids that we're using that are causing harm. And surprisingly, it took a number of decades for people to do a proper randomized trial of steroid dosing, which up until now had been doses that had been plucked from the air from the 1950s and 1960s when steroids were first introduced for the treatment of inflammatory kidney disease. So this is the PEXIVAS study looking at comparing two outcome measures, whether plasma exchange would be of benefit and whether standard dose or reduced dose steroids could be equally effective. I should just add one caveat, which is that reduced dose steroids in this trial isn't what I would call reduced dose steroids. It is in fact quite significant doses of steroids, and I think I'll show you later on that we can use even lower doses of steroids. So what did this study show? This was patients who had what we would call severe ANCA vasculitis, GFRs less than 50 or lung hemorrhage, plasma exchange, or standard or low dose steroid. And you may know or you will know the data from this. Essentially, glucocorticoid dose didn't make a difference to the outcome, which was a combined outcome of death or end-stage kidney disease. But what it did show is that the serious infections at the end of 1 year were significantly reduced by about 30% in the patients who had a lower dose of steroids. The plasma exchange arm, which was a standard of treatment for ANCA vasculitis up until this study, suggested there was also no long-term benefit in terms of survival or end-stage kidney disease, although you will see that there is a slight separation early on, which comes together after 3 years, and I'll come back to that. There was a study from Japan relatively recently that suggested that using half the dose of steroids, so our 1 milligram per kilogram dosing changed to 0.5 milligrams per kilogram, shows equally good remission rates at 6 months between the high dose and the reduced dose of steroids, with a significant reduction in thanks very much. With a significant reduction in serious infections. We went on to show in 2 units in London that you could actually use just 2 weeks of steroids if you combined rituximab and cyclophosphamide together and have very similar outcomes to historic, so this wasn't a randomized trial, this was a cohort study, but similar outcomes to the historic data from patients treated with either single agent rituximab or cyclophosphamide. And long term, what was interesting was only 10% of patients required steroids in the first year to be reintroduced, but by 3 years, 80% of patients remained off steroids, suggesting that the problem might not be with the patients needing steroids, the problem might be with the physicians wanting to give the patients steroids. So if you avoid using steroids early on, you can avoid using them in the long term. So a few years ago, ChemoCentryx developed this drug called avacopan, which is a C5a receptor antagonist, which prevents C5a binding to its receptor on neutrophils and monocytes, causing their activation. And as I told you earlier on, neutrophils are the key component in causing endothelial damage. So blocking C5a through its receptor appears to prevent neutrophil recruitment and neutrophil activation. So the Advocate trial, this was first tested in a phase 2 and then in a phase 3 study, and this is the Advocate trial that compared glucocorticoids with avacopan in the first year of treatment on top of either rituximab or cyclophosphamide. And by 6 months, there was no difference in outcomes in terms of remission rates. By 1 year, there was a slight advantage for avacopan, but between 6 months and 1 year, the control arm had no glucocorticoids at all, so not really comparing like to like between 6 and 12 months. Nonetheless, showing that up until 6 months, you can avoid using glucocorticoids and use avacopan instead. Just to point out, as Magdi has recently said, avacopan is an extremely expensive drug, whereas using very low doses or no steroids is extremely cheap, just to bear that in mind. What was interesting about this study, though, I think what's the most interesting thing about this study was that if you looked at the renal improvement over 12 months, there seemed to be a better recovery of renal function in the patients treated with avacopan. And in this subgroup analysis, this post-hoc analysis of patients who had low GFRs to begin with, there was a significant increase in GFR at 1 year. Now, these 5 mils per minute may not be a huge amount, but considering many of these patients are elderly, 5 mils per minute, and considering we now have other agents that could preserve kidney function in the longer term, those 5 mils per minute could translate to avoiding dialysis altogether. So just back to the elephant in the room about plasma exchange. This has sort of polarized people quite a lot. This meta-analysis from a couple of years ago, looking at all the trials of plasma exchange, if you look at renal survival at 12 months, so independent kidney function, overall there does seem to be a benefit of plasma exchange, although there was no benefit on overall patient survival. So does avoiding dialysis in the first year of having vasculitis, is that a useful thing to do? I mean, that's something you should think about, and if you believe that it is, then the patients who are most likely to benefit, those who've got creatinines over 500 or on dialysis, are most likely to respond to plasma exchange, and you would only need to treat 6 of those patients to prevent 1 of those patients needing dialysis. So we still think there's a place for plasma exchange in people who have more extreme renal impairment at presentation. So this is translated into the current KDOQI guidelines on management. If you have non-organ threatening disease, you can use rituximab or cyclophosphamide with steroids or with avacopan. If you have more severe disease, as we would see in the renal world with renal impairment, either cyclophosphamide or rituximab, with or without avacopan or glucocorticoids, with or without plasma exchange, and also suggesting that our combined regime of rituximab and cyclophosphamide may also have a place for the patients who have the most severe disease. And there may be reasons why you prefer rituximab to cyclophosphamide, and you will know what those are: age, fertility, frailty, and so on. So the problem, I don't think, is getting patients into remission, because I've shown you that a number of different agents can do that. I think the problem is keeping them in remission, preventing relapses, and we still have a very poor ability to define who is going to relapse and when. And so we either end up leaving people on lots of treatment or making the mistake of withdrawing it in the people who need it most. So what about maintenance therapy? A number of different trials, and here the outcomes are not the same. Here there is a hierarchy of drugs that are particularly good at preventing relapse. So cyclophosphamide was better than methotrexate, azathioprine was better than mycophenolate, and the one that trumps it all is rituximab, that seems to be better than azathioprine. So in terms of order of hierarchy, rituximab seems to be the best at preventing relapse, followed by azathioprine or methotrexate, followed by mycophenolate. And this is based on a couple of studies. These are two French studies looking at rituximab versus azathioprine in people who were induced with cyclophosphamide, showing a significant difference, 29% versus 5% in relapse rates. They went on to show that you could maybe tailor this based on measuring anchor levels or CD19 levels and then redosing only when required. But essentially, whether you use fixed dose regimes or whether you use to target regimes based on the antibody, there is a significant reduction in relapse rates if you use rituximab compared to azathioprine. The other study that looked at this was called Rotezoram. This looked at patients who had relapsed and were treated with rituximab for induction therapy, followed by either rituximab or azathioprine for maintenance, and again showed a very significant difference in favor of rituximab preventing relapse. There are some ongoing studies which have not yet reported, combining rituximab and belimumab, trying to have a dual action and prevent relapse rates, and that may, those should be coming out later on this year, but I think are generally looking like they will be positive. Just a couple of subgroups to think about. Granulomatous disease, which I mentioned earlier on, very common cause of morbidity, and this is due to the granuloma formation within the upper airway, here causing nasal collapse, subglottic stenosis, or lung nodules. And some of our previous work, both in vitro and in vivo, suggested that IL-6 was very important in mediating these particular phenomena. What was interesting that came out of COVID was that we were all involved in the UK and in fact in India and across the world in a study called PROTECT-V, which was using nasal niclosamide, which is an anti-helminth drug, to try and see if we could prevent COVID-19 infection in immunosuppressed patients. So a large number of patients, of which a very small number, but an important number, had ANCA vasculitis. We went back to reanalyze the data on these ANCA vasculitis patients who had ENT disease, and we had 14 who were treated with niclosamide and 18 who were treated with placebo. Now, what was interesting was that the patients who had been treated with niclosamide, and niclosamide, I should say, has an impact on IL-6, STAT3 signaling, so it prevents IL-6 signaling. The ones who had been treated with niclosamide had significantly less active disease during their treatment, and if you looked at the subset of patients who were PR3 ANCA positive with that, none of them had disease activity on niclosamide, whereas over half had with placebo, suggesting that maybe thinking about trials using IL-6 in this particular subset may be useful. And then you will know that in the EGPA, anti-IL-5 therapies have now been used for eosinophilic asthma. It's not approved in the UK for treatment of EGPA, but in other countries it is. And these treatment regimens now suggest that maintenance therapy may be useful with mepolizumab or benralizumab in preventing the need for glucocorticoid maintenance. How long should we treat for? The answer is we don't really know. Two very small studies have looked at how long we might treat patients for, 2 years or 4 years, suggesting that more relapses if you treat for a shorter period of time, but that comes at a cost, which is more side effects. The long-term follow-up from these UVAS studies that I showed you earlier on, comparing less than 18 months with more than 18 months, shows that there's about the same number of relapse rates if you treat for 18 months or more. So KDIGO has come out with exactly those recommendations based on these very small numbers of studies suggesting that we should use maintenance therapy either with rituximab or azathioprine in combination with low-dose steroids, that we should monitor patients carefully to look for signs of relapse, and that the optimum time for treatment therapy is somewhere between 18 months and 4 years. But obviously, it depends on the individual in front of you. And there may be reasons why you prefer rituximab or azathioprine. Just very quickly, 2 points on why kidney damage accumulates over time. If you look at long-term follow-up from the UVAS studies, GFR less than 50 seems to accumulate in the patients over a median of 7 years. And the question is, why does that happen? If you look at this cohort study where patients have gone into remission, some of them will have a renal relapse, but only a few of those reach end stage, whereas 3 times as many patients will reach end stage without an apparent relapse. Is this simply progression of CKD, whatever that means, or is this ongoing inflammation that we're not very good at detecting? And I would argue that actually the biomarkers we have at the moment, proteinuria, hematuria, and serum creatinine, are very poor at predicting inflammatory responses in the kidney, taking many, many months to reach their nadir, and in some cases not reaching a nadir at all, with some people having persistent hematuria for a number of years. So this is the analogy. What we're picking up is on the surface. What's going on in the kidney is what we can't really see. And so there is a sort of quest to try and find better biomarkers, whether that is imaging, urine, or some sort of serum biomarker. And there are a couple of these that are currently being tested and may be available as routine, including urinary CD163, or maybe less available throughout the world, but urinary lymphocytes detected by flow cytometry. So in conclusion, I think early diagnosis may improve renal outcomes. Stopping inflammation is critical. We don't have a good way of testing that at the moment. We need some better ways of doing that. And some of the newer treatments will help redefine some of the predictions about how people do in the long term. Thanks very much.
The topic I was given today is to update on lupus nephritis. Right, this is a study which I was asked to carry out more than like 20 years back. It's the first study that I was asked to do by my boss. At that time, the only treatment that we have is steroid plus either cyclophosphamide or MMF. So I look at the survival and also the kidney survival of these patients. You can see that we are not doing a very bad job. In fact, it's quite okay at that time. So the 20-year renal survival is around 80 to 90%. So meaning that these patients receiving a cyclophosphamide or MMF-based treatment, most of them, they don't require dialysis by 20 years. And they do survive as well. So 90% of them do survive for more than 20 years. Nevertheless, the kidney involvement is still very important. So if you have kidney involvement, so you have 6 times of dying as compared to the general population. While if you reach kidney failure, end-stage kidney disease, the risk of dying is 26 times. So meaning that it's very important for us to keep the kidney function. So to preserve nephrons, that is very, very important. So because keeping the kidney function is equivalent to survival. The progress. So these are the different weapons that we have. So Adrian has taught, in the previous lecture, has taught us about the movie, The Lord of the Rings. So a lot of the audience might not have known it. So I try to give you another example. So the corticosteroids that we use are the cold weapons that we have. Cyclophosphamide, MMF, maybe guns. So perhaps the last one we all might know. So different ages, spend a very long time. So Star Wars, so with the lightsabers. So can we use lightsabers? What's next? What is the lightsaber for lupus nephritis? So this is the update from the KDIGO guidelines from 2021 to 2024. So there's 2 additions there you can see. The pink box are the new additions. So apart from cyclophosphamide and MMF that we can use, now we can use a triple therapy incorporating in CNI. So the reason being, I'll tell you why the CNI is being incorporated in the standard treatment. The other one is a B-cell targeting therapy, the belimumab, in combination with our standard of care, cyclophosphamide-based or MMF-based treatment. But why the B-cells? The B-cells are really important because they have a lot of roles in lupus nephritis. We see a lot of autoantibodies in our SLE patients, lupus nephritis patients, they present autoantigens, and they also secrete different inflammatory cytokines, including IL-6, IL-21, BLyS, all these inflammatory cytokines. They're tightly regulated by cytokine as well, by themselves. So one important cytokine is the BAFF, so we can make use of it, so we can attenuate the BAFF, we control the B cells. And also they are regulated by different transcription factors. I'll tell you why these are very important. So targeting the B cells is a very long and tortuous journey. So in 2012, we thought, okay, can we use rituximab? Because rituximab is a very good B cell depleting agent. Nevertheless, the study at that time, the LUNA study, was turned negative. And of course, there are other ways to target the B cells, including targeting the TARSA receptors. And yet this study was prematurely terminated because of infections and also hypogammaglobulinemia. Not until more recently, in 2020, the BLyS-LN study was positive, and the drug has been approved by the FDA as a standard treatment in combination to other standard therapies in lupus nephritis. Well, what's more, you can have a calibrate study, so you can use rituximab followed by belimumab, a very similar concept that Professor Salama has alluded in vasculitis. The Nobility trial works on the obinutuzumab, and of course, there's a reignition of how we use the TARSA receptors. So this is the BLyS-LN study, so published in New England Journal of Medicine. Very landmark trial for several reasons. Not only that it's the first biologics that's been proven to be useful in lupus nephritis, the other thing is that it's just changed how we look at lupus nephritis, how we design the studies for all these biologics. So this is a 2-year studies, randomized control trial. So after that, the different studies investigating biologics, they all have 2 years, because we know that by just looking at a 6-month or 1-year remission rate is not good enough. So there are patients who continue to improve after the first year. So not until at 2 years you can decide whether the patient is really a responder or not. And the other thing is that there's a very, very low or very fast tapering of steroid in the entire regimen. So in the subsequent biologic studies, the steroid regimens, they use very low and very fast tapering of steroids. So in order to show an efficacy of these biologics. So it's just a summary of the results. So if you add on belimumab to a standard of care treatment, meaning a cyclophosphamide MMF, so you've got higher remission rates, you have better disease activity scores, more patients achieving a lower dose of steroids, and of course, more favorable serological markers. And of course, if you look at some post-hoc data analysis, there are some important messages. So the complete clinical response, it's much higher in patients treated with belimumab. It's a complete histological responder, so they repeat biopsy in some patients. So because the biomarkers that we have, urine protein, creatinine, or even the double-stranded DNA or complements, they're not the best biomarkers. So if you do a repeat biopsy nowadays, which is rather popular, so the histological response in patients treated with belimumab is much higher. And of course, the relapse rate is much lower in patients treated with belimumab. So these are some of the other advantages in using a B-cell targeting therapy. So this is a study recently published by our group, so looking at the time points at 2 years, whether they are predictive of the long-term kidney outcomes, where indeed patients who achieve the AMPER, so that is the criteria of remission for the BLyS-LN trial or the complete remission patients. So the responder, they show a much lower risk or much higher rate of kidney survival by 30 years. So meaning that, so if you do better at 2 years, the long-term outcome is very good. And similarly, you can see that those achieving the complete remission or these remission criteria patients, they all have a very good outcome in terms of a low risk of chronic kidney disease, and they also have a much better eGFR. And these data have been recapitulated by another group in the Hopkins cohort. Well, the other thing is about corticosteroid minimization. This is a very trendy thing. It's not just trendy, not just fashionable, but it's and clinically very, very important because and also the use of hydroxychloroquine. So the Hopkins group has, the data from Hopkins group has demonstrated that in achieving a low steroid long-term, it is associated with much better patient survival, and also the use of hydroxychloroquine is very important to prevent disease relapse and much better long-term renal outcomes. There's been emerging data to show all these. And in fact, the use of biologics can help you achieve these objectives, so this is important. What about the CNIs? So this is triple therapy. So actually the data on CNI is that you can either use as a dual therapy in combination with steroid, or you can use a triple therapy, steroid, MMF, and either a voclosporin in the trial, or in the Asia Pacific region we use a lot of tacrolimus. So this regimen looks like what we do in kidney transplant. So there are many studies on this, some from the Chinese group, some from our group, some of the long-term data, and also the voclosporin trials. And suffice it to say, this is a summary of it. So the triple therapy has a comparable efficacy as a standard of care treatment, so be it the cyclophosphamide or an MMF treatment. If you have lots of proteinuria, so it's very good proteinuria reduction because of a CNI that's added, very good long-term disease control, and actually is a quite acceptable long and short-term side effects as we've seen in patients who had kidney transplantation. And of course, there's the concern of chronic nephrotoxicity. Provided that we choose the right patient, we monitor renal function and also the CNI level. So this is, if you ask me how to choose between the two, are in fact, if you have a lot of relapses, then you want to use belimumab. You have a lot of extrarenal manifestations, you might want to use belimumab. But while if you have lots of proteinuria, then you might want to consider a CNI or voclosporin in choosing the treatment. But of course, the other consideration is that whether you have a pre-existing CKD or when you do the biopsy, whether you see a lot of chronic damages, then in these patients, the use of CNI should be more careful. So the biologics, there are two other biologics or B-cell depleting treatment that is very promising. The one is the obinutuzumab, the other one would be CAR-T treatment. I won't go into detail. The obinutuzumab is also targeting at the CD20, but it's a very deluxe version, much more expensive version, but it shows a very deep B-cell depletion because of the various mechanisms, more direct antibody-mediated killing of the B-cells. The tissue B-cells are being depleted as well. And that in the obinutuzumab trials in lupus nephritis, which is a phase 2 trial, it shows a much higher remission rate than the standard arm, the placebo arm, and also a better lupus serology. And in fact, some of the post-hoc analysis of the NOBILITY trial shows that the group treated with obinutuzumab have a less EGFR slope decline in the long run. There's a reduced risk of adverse kidney outcomes overall, and also more patients achieve steroid minimization. The challenge. Well, the challenge is very similar to vasculitis too. It's the relapse. Nowadays, we know how to treat active lupus nephritis, but how to predict and prevent the lupus flares is very difficult. And do the B cells or related signatures have a role in the LN relapse? Oh, sorry that in the next few slides I have to bore you with some of the basic science data, but just to make you think about why the B cells are so important and why we can't really deal with the situation. Okay, this is some of studies carried out before showing that in patients with multiple relapses, when you look at the B cells, there is much attenuation or changes in the expression of the B-cell regulators, including the BAC1, BAC2, and the PAX5, and also some of the microRNAs, that is B-cell signatures RNAs, microRNAs, they are attenuated. So these B cells are really, really problematic in all these patients who have multiple relapses. And when we look at these B cells, especially the memory B cells, because memory B cells, they're easily activated, they are responsible for many of the relapses. So when you stimulate these B cells, in fact, those with multiple relapses, patients with multiple relapses, they have increased proliferation, no matter you stimulate them within a T-cell dependent or non-T-cell dependent pathway. And of course, patients with multiple relapses, they have problems, they have more circulating memory B cells, and also the B cells are more exhausted because they're repeatedly stimulated, and these B cells, they behave very strangely, the exhausted B cells. And therefore, we need maintenance treatment. So very different from vasculitis, the first line maintenance treatments in the LN, it's a mycophenolate. And of course, we can use azathioprine when MMF is not available. And of course, the biologics, some people would use it as a maintenance treatment or CNI. In fact, the two main RCTs that have compared whether MMF or azathioprine is more efficacious in preventing disease relapse, the MAINTAIN trial, largely it's in Europeans, where they've demonstrated that the MMF has an equivalent efficacy in preventing disease relapse as azathioprine, while in the ARMS maintenance phase, it has been demonstrated that MMF shows a better efficacy in preventing relapse in 36 months of follow-up. But what about in Asians? But this is data from Chinese. We don't know how this is applicable in a Southeast Asian population, but suffice it to say, among Chinese patients or Northeastern population, the use of mycophenolate is associated with much lower risk of long-term relapse over 10 years. This is number one. This is the first message I want to get across. If you want to use MMF as a maintenance therapy, at least you have to use it for like 24 months. This is the data showing that if you use it for less than 24 months, the risk of relapse long-term much increased. But of course, there's a cost problem. So if you always want to use mycophenolate, this might be a problem in the Asia-Pacific region. Last but not least is how we can better use our existing weapon, mycophenolate. So one might measure the blood concentration of the mycophenolate during the maintenance phase. So if you keep the trough level between 1.5 to 2, then there's a very low risk of relapse in these patients, and the drug is well tolerated. So one way to better optimize our existing weapons is to measure its blood level, just like what we did in the CNI. The opportunities, okay, this is a tube map from Hong Kong. This is in 1979. It's a time when we first have the subway in Hong Kong. Actually, it is the day when I was born. So I tell you, I just disclosed my age to you. Okay. The one on the right-hand panel, it's the tube map right now in Hong Kong in 2024. You can see that in the old days, we only have one line there. Now there's so many lines, just like lupus pathogenesis. So in the old days, we only know that, okay, there are some autoimmune antibodies. The only thing that we can use is steroids. But now we have so many pathways that we can tackle. It's very complex, you can see. The helper T cells, memory B cells, plasma cells, all these cells are involved in there, and there's so many therapeutic targets that we can try on. But how can we advance the science of lupus nephritis treatment? So the first successful story is a drug repurposing study. So the first drug that we try to repurpose is mycophenolate. From treating patients with kidney transplant, we move it to treat lupus nephritis, which makes a successful story. We publish in the New England Journal of Medicine, and subsequently we try on other transplant drugs, including tacrolimus, and more recently we published on sirolimus, although there are concerns that one might precipitate proteinuria in the glomerular disease, but we tend to use it in patients who had developed malignancy after all these cyclophosphamide or long-term immunosuppression. And of course, the triple therapy is also a borrowing from the transplant community. Well, I'll just show you some of the ideas. What we're trying to repurpose another drug. This drug is called arsenic trioxide. So this is an oral drug that's used in acute leukemia, acute promyelocytic leukemia, suppresses the leukemic cells, and also in the mantle cell lymphoma, which is a B-cell disease. So we're trying to see whether these anti-cancer drugs can be used to treat lupus nephritis. So this is from the mouse. There's a mouse data showing that mouse treated with these arsenic trioxide, which is an anti-B-cell cancer drugs, shows a very significant reduction in their serological markers, improvement in histology, and also in the various immunological phenomena. So this might be one of the, another story which I might have a chance to tell you if you invite me again. So maybe next time. So, and also on the developing of novel treatments, we always have to better understand the pathogenesis or the immunology. In fact, the circulating in IgG is affected by two things. One is the production. So this is very easy. Kill the B cells, kill the plasma cells. So this is by killing. The other thing, in fact, I have to tell you that the antibodies is by research. There's a recycling mechanism. So the recycling mechanism is through something called an FcRn. This is an Fc neonatal receptor. So it brings the Ig into the endothelial cells, do recycling, and they come out again. So there's always two mechanisms, production, recycling. So if you block the recycling, one can quickly reduce the autoantibodies. So this is a phase 1 trial done in our center in the phase 1 trial, showing that if you block the Fc neonatal receptor, one can quickly bring down the IgG. So this would be very, very useful in different kinds of immune disorders, not only lupus, but also in other autoimmune diseases, or even for transplant settings, if we want to bring down the antibodies, the HLA antibodies. So this is a very promising thing. So not only that we published the paper, but also help in the company to be listed in the Hong Kong Stock Exchange. So because I have a habit to look at all the IPO documents, so I suddenly found this company and found that they have listed our company as one of the pipelines. So this is how I found it out. Okay, to conclude my talk, hopefully I have demonstrated or convinced you that the B cells repertoire and the related cellular signatures assume a very important role in disease pathogenesis and relapse in lupus nephritis patients. There's an emerging role of biologics, especially the B cell targeting treatments in the treatment of lupus nephritis, including the anti-BAFF, anti-CD20, the new ones. A better understanding of lupus pathogenesis and immunology may help us to develop the new biomarkers and therapeutics. Drug repurposing, so in the Asia-Pacific region where our resources are more limited, it's a good strategy, a very effective, quick strategy to advance the treatment of lupus nephritis. And of course, the last message, choice of induction maintenance treatment is very important in achieving disease control, and you should take into consideration the following: the disease activity, the prior treatment history, whether they have relapse or not, fertility and pregnancy issues, and of course, the cost and availability in this part of the world. Thank you, and I'll show you a beautiful picture of my hometown.
So I'm going to discuss membranous nephropathy. So first of all, let's set the scene with a typical tricky patient. So a 62-year-old presented to his local hospital with a several-month history of edema. This has been increasing over the last few months with shortness of breath and fatigue. So the patient's blood pressure, 140/95, was very nephrotic with an albumin of just 11, well-preserved kidney function, and huge amounts of proteinuria, and a CT scan was consistent with a bilateral renal vein thrombosis. So the patient started warfarin, and the antiphospholipase A2 receptor antibody came back as grossly elevated at 1,000. So the question is, what are you going to do? Are you going to do a kidney biopsy, and what treatment are you going to start? So clearly this patient needed urgent treatment, had a life-threatening thrombotic complication, and with such a high level of antibody, we knew this patient would be unlikely to spontaneously remit. So we proceeded to treatment with rituximab. Depletion was poor with 2 doses, required repeated dosing, and the levels remained high of the autoantibody. The patient was reluctant to start cyclophosphamide, so we added in tacrolimus. Unfortunately, as sometimes happens, the patient stopped all his medication, went AWOL for a few months, came back to clinic profoundly nephrotic, was admitted with a creatinine of over 400, and now having a 15. So the question is, are you now going to do a kidney biopsy, and what treatment are we going to do next? So the patient had a kidney biopsy, which on low power showed a lot of acute tubular injury because they're so profoundly nephrotic, and the kidney biopsy was typical in demonstrating these thickened capillary loops. Immunofluorescence was positive for IgG and antiphospholipase A2 receptor antibody, and we could see well-established membranous on electron microscopy. So he was treated with oral cyclophosphamide and steroids, and after 3 months of oral cyclophosphamide, we finally started to see a response. And to really consolidate remission, had 2 further doses of rituximab, and 12 months after having further rituximab, finally has a negative phospholipase A2 receptor antibody, and is finally in a remission with a well-preserved kidney function. So we know that membranous nephropathy is the most common cause of nephrotic syndrome in Caucasian adults, and the incidence is between 2 to 17 per million. And as this graph shows, it's a pretty rare diagnosis in childhood, and it really starts to emerge during adolescence to become the commonest cause of nephrotic syndrome in an adult population. We know that untreated, from 5 to 30% of patients will spontaneously remit, and around 25 to 40% of patients will undergo spontaneous partial remission, which is defined as less than 2 grams of proteinuria a day. Unfortunately, about 14% of patients will go on to kidney failure at 5 years, increasing to 35% at 10 years, and at 15 years, 41% of patients will have end-stage kidney failure. We know those patients with high levels of antiphospholipase A2 receptor antibody are a much lower rate of spontaneous remission. So the biopsy looks typical in showing these thickened capillary loops seen on the initial H&E stain. Immunofluorescence will show staining of IgG. This immunohistochemistry quite beautifully shows the staining of antiphospholipase A2 receptor antibody. And on electron microscopy, we see these subepithelial electron-dense deposits, which is all very typical for membranous nephropathy. And the membranous nephropathy results from loss of tolerance to podocyte antigens and the subsequent development of autoantibodies, which is shown here in these pictures. So we have a circulating antibody which will target PLA, and there's ongoing synthesis by the podocyte and delivery of phospholipase A2 receptor to the cell surface. So there's this continued deposit formation. These immune deposits start to activate complement, and C5b to 9, so the membrane attack complex, inserts into the podocyte membrane. C3a and C5a generated, which bind and activated their receptors, and this leads to degradation of cytoskeletal elements of the podocyte. So this results in the podocyte secreting extracellular matrix components, and it's this that results in the thickened glomerular basement membranes. So this is a landmark paper, which I'm sure everyone is familiar with, from 2009, which demonstrated antiphospholipase A2 receptor as the target in the vast majority of cases of idiopathic membranous. So the authors demonstrated by using a Western blot of protein extracts from normal glomeruli with serum from patients with membranous nephropathy. They're able to use mass spectrometry to analyze reactive bands. And as this graph shows, in 70% of patients with idiopathic membranous, there were positive antibody binding to PLA. And this was not seen in secondary membranous, it was not seen in other diseases, nor in healthy controls. And the antibody was an IgG4 subtype. And it's really been the advances in techniques to detect further antigens. And using laser capture microdissection of affected glomeruli, and then digestion and analysis of enriched proteins by mass spectrometry, has allowed the identification of all of these antigens. I'm not going to go through them in huge detail, but following the discovery of PLA in 2014, thrombospondin was the next antigen. And this is associated with malignancy, and it's seen in about 10% of cases of negative PLA. Excitocin was the next antigen, which is associated with lupus and autoimmune disease and a better prognosis, and is seen in about 2 to 3% of cases. Semaphorin 3B is mainly enriched in the pediatric population. NEL1 we'll discuss a bit more later. And also just to mention FAT1, because it was published in KI just this month, how FAT1 antigen was identified in a small number of patients with de novo membranous in renal transplant patients, which is associated with antibody-mediated rejection. And these antigens can be classified. So we have the common antigens, such as antiphospholipase A2 receptor, and the next most common antigen is NEL1, which I'll discuss a bit more later. We then have the disease-associated antigens, and if you're at the talk yesterday, Professor Salama discussed the role of contactin in patients with a chronic inflammatory demyelinating polyneuropathy. And there's then less common antigens, and then right over on the left, there's the rare antigens which have been identified. So how about NEL1? So this is being reviewed in this recent publication. So NEL1 is the second most common target antigen in membranous nephropathy. It's seen in about 5 to 10% of cases once lupus membranous has been excluded. Most cases of NEL1 is not associated with an underlying associated disease. And in a case series of 34 patients with this antibody, 85% of patients did not have an associated disease. So NEL1 is associated with primary membranous nephropathy. There's also been a variable incidence of malignancy in patients with NEL1 membranous, and there seems to be a demographic variation. So the highest incidence in one study was at 33%, and this is compared to an incidence of 4% in patients with antiphospholipase A2 receptor antibody. Even thrombospondin, which is associated with malignancy, that's seen in just under 11% of cases. The original study, which described NEL1 and malignancy, was seen in 15% of cases, and it hasn't been seen at all in the Japanese and Chinese cohort. So there's likely geographical variations for NEL1's association with cancers. How about drugs? There's a recent publication which described 4 patients positive for NEL1 membranous who'd been using this compound lipoic acid, but upon discontinuation of this compound, their membranous got better and they went into remission. How about autoimmune diseases? So a short series described 2 patients with rheumatoid arthritis and NEL1 associated membranous, and there's been unpublished data which has shown an association of NEL1 membranous in patients with Sjögren's syndrome, lupus, and thyroiditis. NEL1's also been described in de novo membranous in a transplant population, as well as patients following hematopoietic stem cell transplantation. NEL1 also seems to be associated with hepatitis and also in sarcoidosis in small case series. So NEL1 associated membranous is not only cause of primary membranous, it seems to be associated with a huge array of other conditions. Okay, so on to secondary membranous. So we know that malignancy is associated with about 10% of secondary membranous cases, with solid organ tumour really dominating, and hematological malignancies is far less common. Patients presenting with malignancy-associated membranous, about 20% of cancers will be seen at the time of diagnosis, and a proportion will develop within a median of 5 years post-membranous diagnosis. Obviously, we know that secondary membranous is associated with rheumatological disease, particularly lupus, with infectious diseases. They can be viral, bacterial, or parasitic. Secondary membranous is associated with drugs, accounting for about 7 to 14% of cases, with non-steroidals accounting for about 10% of cases, which often is not associated with treatment duration. Okay, so in terms of workup for members, if we look at KDIGO guidelines, it does state that patients with membranous should be assessed for associated conditions regardless of their PLAS status. Obviously, this means a full history. Drugs are really important. Recently had a patient who had been given gold by the rheumatologists and developed membranous nephropathy. Obviously, it's important to send off full immunology, virology, scanning the kidneys, an X-ray, and screening for malignancies as per appropriate, taking into account the patient's age and their symptoms. So how about whether we should biopsy or not biopsy these patients? So this was assessed in this publication at the top. And this paper demonstrated in those patients who are positive for PLA in the context of well-preserved kidney function, the patients were not diabetic, in which there was no suspicion of a secondary cause, a biopsy was not necessary, as often there was no alternative cause was found for their nephrotic syndrome, and a biopsy would not have resulted in a change in management. This has been validated in another cohort and has led to KDIGO recommending that a kidney biopsy is not required to confirm the diagnosis of membranous in patients with nephrotic syndrome and a positive antiphospholipase A2 receptor antibody test. But important to state, this is in the context of well-preserved kidney function. Okay, so how do we manage to assess the level of risk? So patients are at low risk who have proteinuria less than 4 grams a day, with an albumin of greater than 30, with well-preserved kidney function, and importantly, no change in GFR, with levels of antibody less than 50, with minimal fibrosis in the biopsy, and are aged less than 50. Moderate risk is defined as those patients between 4 to 8 grams of proteinuria a day, the albumin now decreasing down to 25 to 30, a change in GFR from 60 to 90, and importantly, a GFR that was reducing with antibody levels between 50 to 150 with a bit more fibrosis in the biopsy. So these patients are at moderate risk. How about high risk? So this is more than 8 grams a day of proteinuria, and albumin now dropping down to less than 25, kidney function starting to become abnormal, and over the past year, a change in the kidney function with antibody levels of more than 150 with fibrosis on the biopsy. So these patients are at high risk and definitely a big concern. So once we've evaluated the risk of the patient, those patients at low risk, it's perfectly reasonable just to watch and wait and see. And obviously treating with an ACE or an ARB, with lipid-lowering therapy, with an SGLT2 inhibitor and salt restriction. Those patients who are at moderate risk, it's reasonable to have a limited period of wait and see, then to go ahead and treat. And my first-line treatment will be rituximab, although the guidelines do also recommend a CNI with steroids. Those high-risk patients are going to need to have treatment with either rituximab regime or with cyclophosphamide and steroids. And those patients who are at very high risk, these patients are at great risk of progression to end-stage kidney failure, they'll need to have potent treatment with a cyclophosphamide-based regime. Okay, so all patients obviously have supportive management, diuretics as required, ACE inhibitors or angiotensin receptor blockers, SGLT2 inhibitors, and anticoagulation, and we would generally anticoagulate with an albumin of less than 25. With respect to immunosuppressive management, the original Ponticelli regime that I'm not aware that anyone's really doing much of this nowadays is associated with a risk of cancers, and also it contained a huge amount of steroids, and there'll be steroid-related adverse effects. The modified Monticelli regime uses cyclophosphamide rather than chlorambucil and a lower steroid dose, and it has fewer adverse effects than the Ponticelli regime and is definitely of benefit in those patients who are at high risk of progressive kidney failure. The CNIs, there's a risk of relapse upon cessation of these medications, and rituximab is thought to be less effective when very high levels of antibody are present. And what about combinations? So the MENTOR study demonstrated the use of rituximab in membranous. So all patients had biopsy-proven membranous of more than 5 grams a day, all had RAS blockade with a GFR greater than 40. These patients were treated with 2 doses of rituximab, followed by a second course at 6 months if they'd already shown a response, versus 12 months of cyclosporin, and the outcome was a response at 24 months. So 130 patients were randomized, and when we look at the response at 12 months, very similar between the two groups. However, looking at the response out to 24 months, significantly more patients treated with rituximab had a response of 60% compared to just 20% of patients in the cyclosporin arm. There was also a faster decline in antibody in those patients treated with rituximab. There have been several trials now showing the use of rituximab in membranous. The first trial was actually preceding MENTOR in 2017. This is rituximab versus placebo, and although there was no difference at 6 months, unsurprisingly, it's a very early time point for rituximab. When you look further beyond 6 months and out to 17 months, rituximab was superior than placebo. Starman trial compared rituximab in a low-dose regime, rituximab regime to steroids and cyclophosphamide, and unsurprisingly, steroids and cyclophosphamide was more effective. But I think this goes to show that 1 gram of rituximab just is not going to do it in membranous. That's too low a dose. The last trial to mention was rituximab versus steroids and cyclo, and although steroid and cyclo regime was superior at 12 months, there's no difference out to 24 months. Okay, so how about levels of the antibody? So we know with low levels of the antibody, and decreasing levels, this should predict spontaneous remission, and conservative treatment is recommended. Those patients with high levels of antibody, this is associated with a significant nephrotic syndrome and progressive loss of kidney function. And we know that the serum levels will reliably predict response to therapy. Re-emergence or increasing levels is definitely a time to worry, as this will precede a clinical relapse. Those patients with persistent PLA after initially decreasing re-emergence, again following rituximab, would recommend redosing. And those patients with increasing PLA, despite immunosuppression, then modification is needed, as there's concern these patients are resistant to treatment. A negative PLA at 6 months, very helpful, because this will allow a slow reduction in immunosuppression, particularly a CNI. And early response is key. So this paper from last year used a subset of patients from the mental study, so 85 patients, all had positive antibodies, and they demonstrated it's a change in PLA and albumin level at 3 months that's important, and this was the best risk factor for remission status after 12 months of treatment. And this is similar for the rituximab and the cyclosporin arms, and identified those patients who may need modification to their treatment. And increasing albumin was a better predictor of response than antibody level and proteinuria. Therefore, KDIGO defines that the antibody level at 6 months, if it remains high, to consider a change in immunosuppression. So this flow diagram is quite helpful in telling us how to help deal with those patients who are resistant. And it really depends on what's going on with their GFR. So, for example, if you've initially treated your patient with rituximab or a CNI, in the context of a stable GFR, you may want to redose with more rituximab. But if the GFR is changing, you might want to escalate to cyclophosphamide and steroids. Those patients who are already on cyclophosphamide and steroids, this is very tricky as these patients are going to be high risk of progression. So looking at the KDIGO guidelines, if we look at the antibody levels at 3 months, those patients with an absent antibody level, very reassuring, unlikely to need further rituximab or further cyclophosphamide. CNI, you will need to continue because it's too early to stop. Those patients who have an unchanged or an increased level of PLA, again, consider if you have a rituximab regime, adding a further rituximab or cyclophosphamide, because they are going to need to have an escalation in treatment. And the same goes for looking at the level of antibody at 6 months, those patients who are absent or low PLA or persistent PLA in clinical remission, very reassuring, no additional therapy is needed, and you can look towards weaning or stopping that CNI if they've been treated with that at 12 months. Those patients who have an unchanged or an increased PLA, again, time to worry, as these patients are high risk of progression and we need to have an escalation in treatment. So I'll talk a bit more after the break about obinutuzumab. This is a fully humanized anti-CD20 antibody, which is more potent than rituximab, and has recently been the subject of a trial between comparing rituximab and obinutuzumab in patients with membranous. There were 63 patients treated, and essentially what this showed is many more patients in the obinutuzumab arm responded compared to the rituximab arm. Obinutuzumab resulted in a lower level of CD19, and unsurprisingly, a lower level of greater and significantly greater number of patients had a complete response at 12 months. And obinutuzumab is currently the subject of 2 ongoing trials, which I've just summarized here. What about other treatments? So belimumab is a human IgG monoclonal antibody which binds to B lymphocyte stimulating protein, and was a subject of a trial published a few years ago in which patients with nephrotic syndrome did respond after 2 years of treatment, and is currently the subject of a phase 2 trial. That should be reporting in 2027. Daratumumab targets a plasma cell, so it's an anti-CD38 monoclonal antibody, and his use has really been restricted to limited case reports. This other myeloma treatment, anti-CD38 antibody, has also been used in a limited number of patients, potentially with a response in a handful of patients, and is now the subject of 2 further trials which have completed their recruitment. There's also other potential treatments such as bortezomib, there's plasma exchange, there's CAR T treatment, which I'll discuss more after the break. So in conclusion, there's been great advances in the understanding of membranous nephropathy over the past 15 years, from identifying PLA, secondary antigens, now the widespread use of anti-CD20 depleting antibodies, which should hopefully translate to better outcomes for our patients.